discussing which patient is appropriate for monotherapy versus combination therapy with specifically idelalisib and ibrutinib in our relapsed and refractory CLL patients.
I think it's the right middle. That.
This one?
This one.
Didn't do anything?
It's not working.
No.
Can we have some assistance with the slide? Oh, there we go. Is it working now?
I don't know. Okay, great. Thank you. Okay, so the objectives for this short talk is to briefly review some of the efficacy data with single agent idelalisib and ibrutinib, as well as a few of the presented combination strategies with both of these drugs, knowing that other presenters are going to speak a little bit more comprehensively about these trials. I'd like to discuss some of the potential benefits of combination therapy with these inhibitors versus single agent therapy. I'd also like to present some data on lymphocytosis and persistent lymphocytosis with ibrutinib, as well as some data on relapsed disease with ibrutinib, and to discuss single agent versus combination therapy then with both idelalisib and ibrutinib. So we'll start with idelalisib, which, as we know, is an inhibitor of PI3 kinase delta. Maybe it's just me. Here we go. So the single-agent phase 1 experience with idelalisib was recently published by Dr. Brown, and this study included 54 patients, obviously being treated with various dose levels of idelalisib. An overall response rate through the study was 72%, with 39% of the patients achieving a partial response and an additional 33% a partial response with persistent lymphocytosis. This study determined that 150 milligrams twice a day was the minimal effective dose for this drug and is the dose moving forward. And when you look at patients who were treated with the effective dose, the median progression-free survival is 32 months and overall survival is not yet reached. When we look at the combination of idelalisib plus rituximab, which was presented at ASH and then recently published in the New England Journal of Medicine, we see an overall response rate of 81% for the combination of idelalisib plus rituximab. These data, though showing the survival benefit for idelalisib plus rituximab versus rituximab alone, still have relatively immature follow-up, with only a 3.8 months follow-up for patients treated with the combination. So we don't yet know much about the progression-free survival with this combination. We do have an overall survival rate at 12 months of 92%, though. Idelalisib has also been studied with both rituximab and ofatumumab in a couple of different trials. In one that was presented at ASH this year, idelalisib was combined with either of these two antibodies. Median follow-up was 18 months, and overall response rate for either combination was 83%, with progression-free survival for all patients of 20 months. Idelalisib as well has been looked at with chemotherapy and chemoimmunotherapy, chemotherapy consisting of bendamustine, fludarabine, or chlorambucil, and chemoimmunotherapy, both BR and chlorambucil plus rituximab. And we can see high response rates with all of these combinations, as well as with short follow-up, fairly good progression-free survivals, with the chemotherapy combination with idelalisib an overall progression-free survival of 28 months. So moving on to some of the data with ibrutinib, the inhibitor of Bruton's tyrosine kinase. In the single-agent phase 1b/2 study, which we will hear more about, overall response rate for the single agent is 91% for patients receiving the 420 milligram daily dosing, which is the standard dosing, and 86% for the patients who are treated with 840 milligrams daily. And at 26 months, we have a progression-free survival Oops, sorry, I guess I can't go backward. Okay, so estimated progression-free survival at 26 months of 75% and an overall survival at that same time of 83%. We have seen data already about the combination of ibrutinib plus rituximab from the MD Anderson, where 40 patients were treated. Most were relapsed or refractory, although some were previously untreated. All were with high-risk CLL. And overall response rate for this combination was 95%, including some patients with complete responses, and at 18 months, progression-free survival of 78%, overall survival of 84%. And ibrutinib as well has been looked at with both ofatumumab as well as chemotherapy. And again, these combinations do produce high response rates, and with the follow-up that is available, appear to produce very good progression-free survivals. So in order to address the question of which patient might be better for single agent versus combination therapy, I wanted to outline some of what I think are the potential benefits of combination therapy. And the first, obviously, is to improve our overall response rates and turn our partial responses into complete responses. So as we've seen with both idelalisib and ibrutinib as monotherapy, particularly in patients with relapsed disease, almost all patients are achieving partial responses and very few complete responses. We know from chemoimmunotherapy in CLL that the attainment of a complete response, or in fact a minimal residual disease negative complete response, is predictive of patients who will have much longer progression-free survivals and potentially overall survivals as well. I think what we don't know, though, is whether this dogma that we think is appropriate for all CLL patients is really going to be relevant with the B-cell receptor signaling inhibitors. And I think especially what we've seen with the data with ibrutinib is that even though people are getting partial responses, we have not seen a lot of people progressing, suggesting that maybe with these signaling inhibitors, we don't need to achieve a complete response in order to have prolonged disease-free survivals. As well, there's the potential that, can we go back again? There's the potential that improving the remissions or deepening the remissions may lead to the ability to stop drug in the future. And we have no data on this with any of the B-cell receptor signaling inhibitors thus far. We do know with imatinib and CML that patients who do achieve a molecular response may be able to go off therapy for a period of time and then continue to have disease sensitivity at the time that their disease recurs. Whether this will be true with CLL remains to be seen, but I think that a potential benefit from this might be patients having a time off drug, less toxicity, and of course less cost associated with this too. Can we go back again? So as well, there is the potential, and I think realized, that combination therapy with idelalisib and ibrutinib can either reduce or eliminate the treatment-related lymphocytosis. And I'll present some of our data on the prolonged lymphocytosis with ibrutinib, which I think suggests that this might not be a relevant goal. And as well, there is the possibility that combination therapy might prevent relapse with both idelalisib and ibrutinib. I'll show some of our data on the clinical relapses with ibrutinib, which may help to start addressing this question. So I want to spend just a few minutes talking about peripheral lymphocytosis with ibrutinib. And we know that this is very common and occurs in about 77% of patients that were treated on the phase 1b and 2 trials. Median time to normalization of the lymphocytosis was 6.2 months, and at 12 months, 49% of patients had achieved a partial or a complete response. However, there were an additional 20% of patients at 1 year who still had a partial response with persistent lymphocytosis. And for the purposes of the next few slides, we've defined prolonged or persistent lymphocytosis as that which had not resolved or decreased by 50% within 12 months. So we wanted to look at some of the clinical characteristics or characteristics in general of patients who achieved a complete or partial response within 12 months versus those who would continue to have lymphocytosis. And as was mentioned earlier, the two things that came out were some of our good prognostic factors in CLL. Both the deletion of 13q and IGVH mutated disease were associated with a higher chance of having persistent lymphocytosis. We also saw that the median peak white blood cell count was higher in patients who would go on to have prolonged lymphocytosis compared to those who would resolve more quickly. We looked at the cells of patients who had this persistent lymphocytosis both at baseline and then comparing to various time points later in therapy. And we see that phosphorylation of BTK as well as its downstream target of PLC gamma 2 is inhibited in these persistent lymphocytes, suggesting that our target is still being inhibited and that the B-cell receptor signaling pathway remains inactive in these patients. One thing that came up recently in the panel discussion was this question of clonal evolution in these patients. And while I think that the question is still open, as we don't have a lot of these patients so far, we did do quite a few experiments to try to determine whether these patients with persistent lymphocytosis did have evidence of clonal diversification or clonal evolution. Comparing pre-ibrutinib samples with those attained at 12 months of therapy, we didn't see any difference in IgHV sequencing. Kappa, lambda expression on cell surfaces were identical. Sub-70 methylation as well was identical. And we performed deep sequencing using an ion torrent panel for all of our known recurrent mutated genes in CLL, and really couldn't find any significant changes in the allelic frequency of these mutations from pre-ibrutinib treatment to 1 year, suggesting that these cells potentially are not a significantly different clone or a group of subclones than what was present prior to the initiation of therapy. We also looked for our known resistance mutations of BTK and PLC gamma 2 and by deep sequencing and couldn't find any evidence of those in these cells. And as well as was mentioned previously, we did Ki-67 analysis of these cells pre-ibrutinib and then after 9 months of therapy. And while we know in CLL most of the peripheral cells don't proliferate, we did see that there was some proliferation in these cells at baseline, but when we looked at 9 months, there was virtually no proliferation, suggesting that these cells are not active in the circulation. We also were interested to see whether these cells might be dependent on a kind of a single survival pathway that might give us a rationale for a combination with another targeted agent. So we looked at some various inhibitors of the B-cell receptor signaling pathways, as well as other kinase inhibitors. We looked at a PKC beta inhibitor, dasatinib, which would target both BTK and LYN, AKT inhibitor, PI3 kinase gamma delta inhibitor, a MEK inhibitor, and dinocyclib. And we saw that while many of these agents were effective in these persistent lymphocytes, we didn't see any differential efficacy pre-ibrutinib to after ibrutinib therapy, suggesting that those would not kill these cells in a targeted fashion. And probably most importantly, we looked at progression-free survival of all the patients enrolled on the phase 1b/2 study in a landmark analysis from 1 year, dividing patients up into those who had attained a PR or a CR, shown here in black, versus those who had a PR with lymphocytosis, here in red. And so you can see that from 12 months, the progression-free survival for patients with persistent lymphocytosis is the same as those who have attained either a CR or a PR, and actually trends towards being improved for those patients with persistent lymphocytosis. So to summarize these data, persistent lymphocytosis is common, not associated, at least with our follow-up so far, of a poor prognosis. I think the randomized trials that are currently being performed will help us decide whether there are any consequences of this lymphocytosis, whether it provides immune suppression, whether there's any other negative connotations. But we have no data at this time to suggest that this is the case. And as well, specific targeted agents don't appear to have differential efficacy, but probably there's no reason to try to target these persistent lymphocytes. So I wanted to present just a little bit of data as well on our single-site clinical experience with ibrutinib, and specifically with the discontinuation of ibrutinib. We've treated a total of 267 patients on 3 completed clinical trials. Median follow-up for this group is 16.5 months. There are a few patients who went on study very recently, but we also have patients out to 42 months of therapy. And of the 267 patients, 201 remain on ibrutinib, 24 discontinued due to disease progression, 22 discontinued due to infection, 8 came off for another adverse event, 4 went on to stem cell transplantation, and 8 came off for other reasons, which was mainly that they were able to get ibrutinib commercially, move to another site, things of that nature. When we look specifically at the patients who did have disease progression, Richter's transformation occurred in 16 patients, and this was mostly diffuse large B-cell transformations. And CLL progressions only occurred in 8 of our patients. 3 of these were on single-agent ibrutinib, and 5 were on the combination of ibrutinib plus ofatumumab. We looked at some factors that could be potentially related to the discontinuation of ibrutinib, and this is a multivariable analysis. We saw that increasing age, increasing RI stage, an increasing number of prior therapies were all associated with an increased risk of coming off of ibrutinib for a reason other than disease progression. We saw that higher LDH at baseline, presence of BCL6 on FISH, and a complex karyotype were all associated with a higher rate of relapse. And specifically in our group, these were all associated with a higher rate of Richter's transformation, though I think that's probably related to our small number of patients who had disease progression with CLL, because you can see that all of those factors showed a trend in our CLL relapses towards being significant as well. And we also see that the 17p deletion, well, that has been shown in some of the studies to be associated with worse progression-free survival with ibrutinib. It was trending for both CLL relapses and Richter's transformation, but did not reach statistical significance yet. So to summarize these data, with prolonged follow-up, we have very few patients who have relapsed on ibrutinib. The ofatumumab combination does not appear to prevent relapse, but whether those patients will have longer progression-free survival does remain to be seen. Patients with complex karyotype appear to be at a higher risk for relapse, as well as potentially patients with 17p deletion. So getting back to our major question is which patients might benefit from a combination rather than a single agent. I think starting with idelalisib, I think that you could make the case that all patients might benefit from a combination strategy with idelalisib. We've seen from the phase 1 data that there are prolonged remissions with single-agent idelalisib. It's certainly an effective agent by itself. However, most of those patients have come off therapy and potentially would benefit from a combination strategy. I think in particularly the high-risk patients, what was seen in the phase 1 trial is patients with 17p deletion or p53 mutation did have a very much inferior progression-free survival, only 5 months compared to the 32 months overall. 11q deletion didn't seem to be a risk factor with a single-agent idelalisib, but NOTCH1 mutation patients also appeared to have inferior progression-free survival. Dr. Coutre at ASH this year presented some data looking at both single-agent and idelalisib combinations, and we didn't see a difference in response among these different poor-risk groups, so suggesting that maybe these patients are responding but just don't have the disease-free or the remission durations that the patients without the high-risk features did have. And then switching over to ibrutinib, I think that it's not as clear that that the majority of patients attain benefit from a combination strategy with ibrutinib. We see with the phase 1/2 data that there are many patients who are out over 3 years with no signs of disease progression. And potentially, there are patients who might benefit from a combination strategy. I think particularly those with complex karyotype. From our overall data with the phase 1b/2 trial, as well as the MD Anderson rituximab ibrutinib trial, potentially patients with 17p deletion have a shorter progression-free survival. Although the trial from the NIH actually has not shown that to be true, that trial, though, including more treatment-naive patients. So to conclude, I think idelalisib most likely should be given in combination, as has been done with the idelalisib rituximab trial, especially for patients with high-risk disease. So maybe we will be able to identify patients at some point who would benefit only from single-agent therapy. I think ibrutinib is reasonable as monotherapy in the majority of patients, although patients with complex karyotype and some of our other adverse features might benefit from a combination approach in clinical trial setting. But I think probably the most important thing is that as these drugs become more widely available and standard, it's still important to consider clinical trials for your patients, especially looking at different combinations or other alternative agents which may help us answer these questions more definitively. Thank you.